sorry, bear with me everyone, I'm just having a look at how many people got in here, like 8 attendees, so stop sharing. How do I? It's not working. Right, I shall start if that's okay, and we'll slowly hopefully see some more people start joining. So my name's Pat Haslam, and we're just going to run an hour session today. This is the first of 2 that we're doing as part of the MBRN on COVID-19. I hope everyone finds it useful and enjoyable. We've got quite a bit to go through, so we'll crack on. I'll mute that other computer. I think major IT confusions at the moment, because of my simple mind. So, sorry, today's session is on the acute presentation and management. So we've got Tim Gatheral and Catherine Pryor from the hospital talking firstly with Tim about the acute management, some experience at the hospital so far with coronavirus infections. And then we've got Catherine talking a bit about the medical pathway and some insights into the long-standing symptoms of so-called long COVID after that. So we'll try and get through those at around about 20 minutes each or quicker, and at the end we'll have some time for a Q&A if people want. So the way this works, we think, is if you submit a question to the Q&A section on the Teams page, there should be a little bubble to the right that says live event Q&A. If you submit loads of questions that you have, I will have a look through them and try and pull them all together, and then we'll just grill Tim and Catherine in depth about everything. So if you just throughout the session, if you want to submit the questions there, I'll be having a look and we'll bring them up at the end. The second session, which is on the 4th of November at 12:30, will be myself and some of the team from the rehab service talking a bit more about follow-up after not only admission to hospital for these patients, but also those patients who got severe infection but weren't admitted. So a bit more in depth about long COVID, the follow-up in primary care, and then some detail around the rehab pathway, and again we'll have a Q&A. Just a couple of housekeeping things. So just so you're aware, everything is recorded from these events and they'll be available afterwards. So if you have colleagues who weren't able to attend, they can watch the video. As I said, it's not actually, sorry, I need to redo that. It's not posting any questions to the chat window, although you can if you want. But ideally, if you submit them to the Q&A tab on Teams, we'll pull those together. And then just a little bit to say that we're close to getting our coronavirus dashboard together. It should be available for everyone across the bay, looking at admissions, diagnoses, positive tests and things like that across the whole bay. Got a bit of details to sort with that, but it will help practices identify who was positive, who was admitted, and there'll be some interesting data around various characteristics of the patients that we'll be able to look at, as well as things like excess deaths for each practice and ICC. Also worth saying, this operates in the background of all the wider pathways that we have with coronavirus in Morecambe Bay. And hopefully most people will be aware that we put together a Morecambe Bay pathway protocol together that was distributed back in April or May time. It was approved by IMT, which is the leadership team for the COVID response, and provides some useful information on assessment, management, oxygen, and various things for people. That's being updated as we speak and is very close to being done, and we'll send it out again shortly, hopefully with a view to looking forward to the next wave, such as it is over the coming months. So that's all I was going to say. So I need to end my sharing of the screen, and it needs to go to Tim for the first talk, if that's all right.
Thanks very much, Pat. Can people hear me okay? I don't know if this headphone's working. Yeah, okay, I'll just crack on them. Right, let me just share the screen. Okay, hopefully everybody can see that. So thanks very much. So I'll try and rattle through this, focusing on the more interesting bits, because there's a few slides here. So unfortunately, as you know, we're heading back into these patients coming into hospital. It makes it a lot more relevant to be talking about this now. So unfortunately, all our lives have been turned upside down by this virus. It's a novel coronavirus of likely bat origin, possibly also an animal called the pangolin, which we learning more about, but we're not quite sure. But anyway, it was a cluster of atypical pneumonia noticed in the city of Wuhan in China in late 2019. The virus is genetically similar to previous severe coronavirus infections, so SARS and MERS, and these cause very severe viral pneumonia with mortality rates of up to 30–40%, but far less spread of those. They were very localized to the Middle East, for example, with MERS. But very similar in structure. But unfortunately, as we know, this has gone on to form a global pandemic. As of yesterday on the Johns Hopkins site, 37.5 million infections and over 1 million deaths. There will be more infections, of course, than that 37 million. That gives you a mortality rate of that data of about 2 to 3%, but the true mortality rate is thought to be less than 1%. When you account for all the asymptomatic carriage and so on. So it's important to say the majority are asymptomatic or have low severity flu-like illness, but unfortunately a small, but in these numbers, significant number of patients will develop severe respiratory symptoms. Some of them will require admission for oxygen, non-invasive or invasive ventilatory support. So how is this spread? Well, the best available evidence still suggests this is a droplet spread disease, so very similar to influenza. There has been some scientific study of this, as you can imagine. So a paper or a letter to the New England Journal quite early on in the pandemic in March showed that the virus could be viable and detected in droplets up to 72 hours on certain surfaces, especially plastic and stainless steel. Now, it doesn't necessarily mean that that virus is infective to another. It's difficult you can't really experiment that, obviously, but certainly viable virus could be seen under the microscope. So that is not entirely surprising then that there's been widespread transmission of this disease because of that. But we also know the virus can be aerosolized experimentally, and that has led to concern over particularly hospital spread with aerosol generating procedures. So we've all become used to these terms in hospital, AGP. So for us in respiratory, that's obviously high flow oxygen, non-invasive ventilation, and if the patient requires intubation or endoscopy, bronchoscopy, these are all aerosol generating procedures. Very recent paper in the Lancet looked at a big meta-analysis of all of these rules and regulations that we're living by, which does suggest significant benefit of social distancing greater than 1 meter and face mask use. I think the only thing is it's very difficult to actually very scientifically measure the effect of these interventions, because you're talking about large populations, different social settings, hospital, out of hospital. So it's actually very difficult to know, but these things seem to be accepted and common sense. So these are some examples, to say, of AGPs. So we have a lot of patients now. We're tending to favour, as I'll talk about later, nasal high flow oxygen, which you see on the left. A patient in the middle is non-invasive ventilation, or CPAP, interchangeable really, and unfortunately a small number of patients, but significant, do require ventilation and intubation. So these are all aerosol generating, so extreme care and full PPE is needed, but not nebulizers. That's not an aerosol generating procedure. Nasal cannula and face mask oxygen is not. Officially, spirometry is not, but there has been a lot of debate about that, and we're adopting a common sense approach with full PPE for spirometry. For example, physio with induced sputum would be regarded as aerosol generating, so spirometry probably should be there, really. I think I'm not going to do this to death. We've all watched the news, we've all seen these patients. Many of you will have had it themselves, I suspect, unlike me, but fever, very odd myalgia, very strange. I've never quite felt that before personally when I had the virus, but very odd myalgia, that's quite a telling symptom. Dry cough, perhaps a bit less of the more coryzal symptoms, but loss of taste and smell is there as another sort of specific thing, or more specific thing for COVID. So fever is pretty ubiquitous, perhaps in the elderly frail as often we can get slightly atypical presentations and delirium, so we've got to remember that, but the other symptoms are pretty common, as you see. So the key is that you have an early stage, which is like any viral infection, with fever and generally feeling unwell and perhaps not too unwell. But the problem seems to be this host inflammatory response, which builds up particularly around day 10 and onwards as days 7 to 10. And it's felt that host inflammatory response is leading to the severe respiratory failure in a minority of patients. The only caveat to that is the early studies in China did suggest that viable virus was isolated for a lot longer in patients who have more severe disease. So I think one does have to be a little bit careful to blame it all on the immune response. There may be some people that don't clear virus effectively compared to others. So obviously this is what's been occupying myself, Catherine, and others in the hospital, is the severe form. So as I say, day 7 to 10, pneumonitis and respiratory failure. It's been noted that some of these patients can actually be relatively asymptomatic initially, but profoundly hypoxic, and ambulance crews are picking these patients up with SATs in the unrecordable, but actually chatting away. And I can certainly attest to that. But certainly it progresses in the severe form to very severe breathlessness, very high respiratory rate, ground glass and consolidation on the CT scan. Some other prognostic markers, severe lymphopenia is something that's been identified independently as a poor prognostic marker, high D-dimer to a degree, high CRP. And we know that along with the lung disease, we can get myocardial involvement, coagulopathic, particularly if they're multi-organ failure on ITU, and some neurological dysfunction. Post-mortem studies showing virus within the CNS has also been reported, and we're still trying to clarify exactly what that all means. That's just a fairly dubious slide, but showing bilateral ground glass change that one might see in COVID. We don't CT all these patients, and the X-ray is often very telling in the right clinical situation with a positive swab. I won't dwell on this, but this is some early data from China. Remember, this is patients that are coming to hospital, so by definition already a severe group, so the mortality has to be taken with a pinch of salt here. But of those coming to hospital or symptomatic with positive swabs, the overall fatality rate was 2.3%. I do think it's important to note that of healthcare personnel infected, the effective case rate fatality was very, very small. It's not negligible, sorry. And of course, it's very emotive. We know colleagues that have been affected and died. I certainly do across the country. But one must also put risk into context to enable us to all work. And the risk is very low with the right precautions. As I alluded to, and as we know, older age is the major risk factor for death and more severe disease, D-dimer in this study to a degree. And as I say, in the survivors, the viral shedding seemed to stop earlier, suggesting maybe it was a way of handling the virus. But we now know that later on with the steroid studies and so forth, that host immune response and inflammation is a big factor. Initially, it was a very deadly disease. Even patients were offered the absolute pinnacle of care in high quality intensive care units in Italy and elsewhere had very high mortality. That has improved significantly. So where were we? Well, we didn't have any known antiviral therapy. We had a real lack of consensus on the best way of managing these severe patients. Should you get them straight to the unit if they're suitable for intensive care and intubate them early, or should we use non-invasive ventilation in its various forms to prevent that? Should we stop steroids? Should we start steroids? Should we give antibiotics? Should we be Norway or should we be Sweden? That's about the politics, which I certainly won't get into. But these are all questions at the beginning. We had lots of potential treatments. There's nothing like a pandemic to get everyone's opinion on the table. And if anyone hasn't watched the film Contagion, it's particularly relevant to a lot of the stuff that's gone on. But chloroquine, hydroxychloroquine, azithromycin has largely been pushed to the sidelines. There's not been any convincing data, and we know these drugs can cause harm. Remdesivir I'll touch upon later. Other antivirals were considered, but no real evidence has emerged. Tocilizumab's an anti-IL-6 anti-inflammatory that has been part of the clinical trials, but nothing convincing. And obviously Donald has weighed in with some helpful suggestions. Don't try this at home, kids. So what did we find? I'm going to whiz through this. These slides I've stolen a bit from Pepper, our fantastic registrar, who did a lot of work on an audit with others. We just wanted to see what happened to our patients that were admitted in the first wave who were positive and ended up receiving CPAP. Most of these patients were deemed not suitable for escalation to intensive care because of comorbidity or frailty. We wanted to look at mortality and discharge, etc. I'm going to whiz through, but we had 380 patients that we checked the records for. Of those, 57 had CPAP with a positive diagnosis. This is a very large cohort to compare to many of our peers in the Northwest in terms of the data recorded. 10 were admitted to ICU, so the majority were those that weren't admitted to ICU. So 46 patients in the end, including our study. I think this is a pretty sobering statistic that of those 46 patients, 34 died despite this very intensive non-invasive therapy, only a 26% survival rate. Which has raised sort of questions in my mind and others about what treatments we should be offering this group of frailer patients. As you might expect, the non-survivors were older by over 10 years, more likely to be male, and interestingly, in our study, the BMI didn't seem to have an impact on the survival. But you've got to remember, we're just looking at people with severe disease and who are more likely to be overweight to get the severe disease, if you see what I mean. Of all those who died, they had a DNAR in place. There was a mix of comorbidities, but not a significant difference really between the survivors and the non-survivors in this study. Possibly dementia at the bottom there's a bit of a signal which has been borne out in the national data. I'm going to move through that. This is just to show that it wasn't well, it just about reached statistical significance of the lymphocytes. The lymphocytes were lower in the non-survivors, and that's again backing up data that's been seen in international studies. The CRP was also a little higher in those non-survivors, but there wasn't any difference in D-dimer. The creatinine was worse in the non-survivors, suggesting it's either chicken or egg. These are sicker patients who've begun to go into multi-organ failure. And this was really just to say that there wasn't any delay in the non-survivors getting onto CPAP. They were actually got onto CPAP quicker, probably suggesting they were a sicker group when they first presented. That's not particularly relevant. So I think just a quick overview of our data really before in the first wave, that of those who did survive CPAP, I mean, these are patients generally who weren't for escalation to ITU overall, but the ones who were for escalation to ITU had a better chance because they were fitter patients. That's why we felt they were suitable for ITU, but otherwise the survivors were younger by a considerable margin. And the BMI I don't think was truly a factor. Let's move on. That's not, again, I'm going to just skip over those slides because we haven't got an awful lot of time. That's just making that comment, as I say, that the survivors started CPAP later, so perhaps they were a less sick group initially in hospital. There was it's not a controlled study, it's retrospective. There was variance in which clinician did what when, because we didn't have any adequate guidance to tell us what to do. And I suppose the worry is, should we have started CPAP early? Should we have done more proning, which I'll mention later, but again, no guidance. And also, did we use CPAP inappropriately? Did we actually prolong suffering for some patients? I think these are really important questions. And our conclusions from this was that mortality for those who are unsuitable for ITU, who are frail, and with the most severe form, the mortality is horrendous. And actually, my feeling going forward is we have to be very careful who we put onto these pretty unpleasant treatments if it's looking hopeless. But there's no official guidelines, so it is very much clinical judgment. But I think early involvement of palliative care and symptomatic relief, just in case drugs, is really important in this group as well. Where are we now? Just to very quickly talk. So the recovery trial has changed things around for us. An open label UK, but a placebo-controlled trial. We had excellent recruitment locally, and it's been a real success for the UK. This study led the world. Those were the drugs that were in the treatment arms, but I'm going to focus on the dexamethasone, which has been the positive outcome of this study. And in the study, 2,000 were randomized to dexamethasone versus 4,000 odd in the usual care group, so just a standard of care. And the overall figure is that mortality in the dexamethasone group was about 23% compared to 26%, should we say. So a modest overall risk reduction with a relative risk of 83% on dexamethasone of dying. However, this was clearly weighted to the most severe patients, because the mortality in the patients requiring ventilation was 30% versus 40%. So that's a much more significant relative risk reduction. And there was also still seen that risk reduction in patients who needed oxygen, but there was no effect of steroids in those with more mild disease who did not require oxygen. All right, so that's the important thing. The sicker you are, the more respiratory support you're requiring, the more likely steroids are to help you. These are relative risks, not absolute risks. I mean, the absolute benefit of steroids is still going to be much lower than this, okay, because most people don't die of the disease. Despite all the papers tell you. The other drug that's come into attention is Remdesivir. My personal view is this has been a wonderful success for the shareholders of the company that makes it, because an awful lot of rather dubious science has gone on to justify its use, but that's my personal view. It is a prodrug that's known to have inhibitory effects on other viruses, and it was trialled in the West African Ebola outbreak, but no proven benefits. There was a rather shaky basis, but there has been some in vitro data that it could be effective in coronaviruses. An initial Oxford University funded or supported Chinese randomized control trial, double blind, did not show any statistically significant benefit on mortality, but a trend to reduce time to clinical improvement. But there were side effects that led to people discontinuing the drug. There was a follow-up study in the National Institute of Health in the US, published in the New England Journal, that again has not shown a statistically significant survival benefit of Remdesivir, but a shorter recovery time, about 10 days compared to 15, including the most severe patients. And that has therefore led to cautious approval of it, certainly in the US and in Europe, to be used for patients who require oxygen. So similar to the steroid picture, but I remain to be personally convinced that it's a wonder drug. Right, so what I'm going to do, this is a current UHMB, this is my last bit. I was just going to pop up what we're currently doing. Okay, so sorry this is in a Word format, but it's best I can do it. Hopefully you can all see that. So this is what we've decided to do with the second wave. So the first thing is if they come into hospital with a positive swab, but without significant clinical features of COVID-19 viral disease, so none of the classic symptoms that you see on the left in group 1, not requiring oxygen, etc., then we will follow our infection control procedures with using the correct PPE, which is gloves, apron, surgical face mask, and cohorting of the patients. But no specific therapy will be given to them. No steroids, no remdesivir. We will just treat them for the presenting of plate, assuming that this is largely incidental disease. We treat them for what they've come to hospital with. However, if they do have relevant symptoms that I've already mentioned in the talk, myalgias, fever, loss of smell, taste, cough, etc., without any other obvious respiratory cause, and again, we're going to follow the infection control procedures of the trust, cohorting these patients. If it's only a suspected disease with a negative swab initially, we'll try and get an urgent repeat swab if we're clinically suspicious, because we know we can get false negatives. We're going to do lots of tests, including the D-dimers, the CRPs, the full blood count to see if we can get an idea of severity, certainly a chest x-ray and possibly CT imaging, particularly if we had high suspicion of PE, which we know is a bit more prevalent in COVID, or if there's ongoing doubt about the diagnosis. Now, if it's non-severe disease, so they don't have significant pneumonia, they don't need any oxygen, there's no features of sepsis or organ dysfunction or neurological impairment, then again, we're just going to treat them as we would any viral flu with supportive care. One can talk to the clinical trials team to see if there's any relevant studies that are applicable, but not for other therapy. If, however, they have severe COVID viral disease with evidence of significant pneumonia requiring oxygen or perhaps other features of organ dysfunction, then we're going to step things up. Now, this is my last sort of slide here. The most important thing is early assessment of the ceiling of care. We don't want to be in the middle of the night with a patient we don't know whether they're for the unit or intubation or not, and no discussions have happened, so that's really important. And there's no blanket rules on that. It's as we always do for patients to decide whether ITU is appropriate. Then we're going to follow our respiratory guide. We're going to zone them to the right ward. And the main difference is, compared to the first wave, is we're now going to give these patients systemic corticosteroids, most likely dexamethasone, 6 milligrams daily for 10 days or until they go home. And that's based on the recovery study data. Given that the absolute benefit may be actually quite small in some patients, if they're fairly mild with perhaps needing 2 litres of oxygen and they've got terrible diabetes or other recent GI bleed and stomach ulcers and all, we'd still use our clinical common sense and we'd have to weigh up the pros and cons of steroids, but in general we should use them in the severe group. We provide an enhanced heparin prophylaxis because we know there's a risk of a hypercoagulable state, and that's a protocol based on weight and their creatinine clearance. No other therapies have proven effect. The Remdesivir has limited trial evidence, as I've alluded to, that it may shorten the course of illness but not affect mortality. We have limited stocks of this drug. There's lots of politics around this internationally, but we do have limited stocks, and essentially this is a sort of several consultant decision as to whether to use it or not. So there's one chap I prescribed it this weekend when I was on call who was very severe and ended up on the unit. So that's really the change. And then we've got a fantastic research and development team who are offering several clinical trials, which are generally of novel anti-inflammatory agents to see if they will boost the steroid effect. And finally, then, for those that are needing higher flows of oxygen that perhaps aren't needing the unit, we are favouring now high flow nasal oxygen over CPAP. There's good evidence that it doesn't produce more droplet spread than even face masks, really, if done properly. So it's not endangering our staff, we think, to any great degree. It's well tolerated by the patient. The patient can still eat and drink. And it seems to have has good outcome. There's no convincing data that it doesn't. CPAP will be the next therapy we'll try, but as I said before, we're going to be quite discerning in who we use it. If the patient's very frail and perhaps dying, I don't think it's appropriate that they're plonked on CPAP just because we can. Proning is something, moving the patient onto their tummy to improve oxygenation. There's weak evidence for this, and that's something we will explore more if we get a large number of cases coming in. So that's a rattle through the acute management. The key change is the steroids, thinking about Remdesivir, and perhaps being a little cautious about putting frail patients onto quite unpleasant therapies. My personal view, the virulence of this disease appears to be slightly different, slightly less, in my personal view, in the majority of patients that have come through the ward over the last 2 weeks. Most of them are getting better after a few days, even if they've been on high flow oxygen, which was not our experience before, as you saw from that very horrible mortality data. But the reasons for that aren't clear. There aren't as many numbers at the moment, so we just have to hope that maybe that is a trend that continues. I'm going to stop talking. I've probably gone way over time, but any questions down the line are gratefully received.
Brilliant, thanks Tim. So it's fantastic. And just very quickly to say before Catherine does her talk is just a reminder, if I can share this screen. Are you sure you want to share? Yes. So if you see over, hopefully you'll see on my screen here, just on the right, there's the live event Q&A. That's where you can submit questions to us, and we'll try and pull that together at the end of the meeting. The other thing I wanted to say is wrapping around that initial assessment management in the GP pack that we're going to be sharing. This version has been, previous version has been shared, but we've been updated. It includes some pointers. It's not a new guidance, it's pulling together of all the relevant guidance that we have about community triage and some advice about the initial assessment and management in the community, which we'll talk again about in our Q&A session at the end, but it provides some advice for community colleagues and GPs seeing these patients. So if you just remember to as many questions as you can, that'd be absolutely brilliant. And I'll hand over to Catherine, who can do her next talk. Hello, Catherine. Catherine, you're muted.
I've sent her to sleep with my talk.
Catherine, are we there? You're muted if you're talking.
Sorry, I couldn't find the unmute button. Is that all right?
Yep.
Cool. We've got the slides up, everybody.
There's nothing there at the moment, Catherine. Have you shared your screen?
Yeah, I've shared my screen. Is it up now?
Hey, there we are. Perfect.
Okay, so essentially what I'm going to talk about is COVID recovery, because I think that's what we need to focus on here. And a lot of this is a complete evidence-free zone and has been researched from a number of places, including Facebook. So from the start, so why do we follow up the patients following COVID-19? So we initially had some data back from the SARS and Middle East Respiratory Syndrome virus data, which was pre-COVID.
Catherine, sorry, can I just interrupt you a second? It's just shared in a very strange way. I think other people might have seen this. If you just restart the slideshow, but don't uncheck the presenter view box, I think you should see.
Yeah, I can see it. It's misbehaving, Pat.
It's misbehaving, so we're just seeing your notes rather than this.
Yeah.
Slide. So we'll try again.
Is that better?
No, I'm still just seeing the slide notes.
Yes.
If you share your screen, but share, if you've got two windows, two displays for your computer.
No, I've only got one, Pat. I'm on a laptop.
This is very strange. So I don't know what to say.
On the slides, and I've gone to the start of it.
Yep. And then
so Catherine, it's Suzanne. If you just stop sharing your screen and then share it again, but make sure you're selecting desktop rather than this. Don't select the PowerPoint. Select your desktop.
Yep, got it. There we go.
And then go to the PowerPoint, and then we should be able to see it in full screen.
Cool, thank you.
Yep.
So sorry, I'll start again. So going from here. So why do we follow them up? Number one, we've got some evidence showing from the MERS and SARS viruses, which were back in the year 2000, that actually people did have persistent changes on both their CT scans and in pulmonary function tests, that they went on to develop a post-viral fibrosis. So in their cohort, they did see that 30% of those with SARS and MERS did have persistent CT scan changes with persistent ground glass opacities, and after 12 months this was improved, but they did notice that the functional impairment on these people in their lung function tests and actually in their physiology studies did actually show that this was mainly due to muscle weakness and deconditioning. And our concern with the post-pulmonary fibrosis is that actually we have an aging that we have actually an older cohort than probably did that actually had MERS and SARS. And these are multi-comorbid with increased risk factors. And of course, we've got a far bigger cohort than ever before, which need to be followed up. And so therefore, we do follow them up with chest X-ray for that, for pulmonary fibrosis and pulmonary function testing if indicated. The other concern that we've seen is there is potential risk of viral myocarditis with COVID. And there's very few studies on this, to be honest, out there, but there is a proposed indicator that approximately 20% of cases in China had myocarditis with arrhythmia within 16% of these. And actually, if you had myocardial involvement with your COVID infection, the death rate was much higher at 52% compared to about 4%. The only follow-up series I've seen has been a series of patients where they carried out MRIs of American football players in order to see what was happening with the heart, and myocarditis or changes consistent with myocarditis were seen in 15% of their cohort. And so therefore this is an important consideration that we need to keep at the back of our minds. Secondarily, we follow up all those with pulmonary embolism, as approximately under 5% go on to develop long-term problems associated with this, but this is part of our normal follow-up for this disease, but we need to remember to do this. We see a significant amount of deconditioning from being in bed, being on ITU. Patients suffer a great deal from being post-ITU, and it is well known in the literature and certainly amongst the respiratory community that we say it can take over a year to recover from an ITU stay with ventilation. There is a large degree of post-viral fatigue that we're seeing, and these patients actually have a great deal of psychological trauma related to what they have seen, what they have undergone, and actually been told even that they've got COVID-19 and the reaction due to that. So this is one of the few slides that has come up related to follow-up, and this is from the Italian cohort based out of Milan. This follow-up was anything up to 3 months, so you can see that there was fatigue, 80% of them during the acute phase, but even in follow-up, 50% of them presenting with fatigue, over 40% of them have breathlessness, and subsequently going down through joint pain, chest pain, cough, anosmia and phantosmia, which is the horrible smell within your nose, and Zika syndrome, as well as multiple other symptoms that they are still presenting with. And these are in hospital-based patients. The cohort data that we have in the UK is related to only one cohort, which we've seen. And this cohort is actually part of SWAP and the Mandels data at the Royal Free Hospital, of which they have currently followed up 384 patients of a median follow-up of 54 days post-discharge. This is before the 3 months that the BTS has actually recommended for follow-up. And these were swab positive who were admitted hospital, so mean age of 60, 62% male, 43% black and ethnic minority. But I think what this shows is that a significant number of them had significant fatigue, they were breathless, they were still coughing, and a significant number of them still had psychological issues. As regards follow-up with related to blood tests, you can see that the breathlessness scores got better, but with blood tests, a number were still lymphopenic, they still had elevated D-dimers, and they still had elevated CRPs. And finally, with chest X-ray follow-up, we can see that a number of them had improved significantly following discharge, but there were a small but significant minority who still had changes who we need to make sure that we are picking up and following up. And this is why we picked up this group to follow up. So chest X-ray if indicated, so if they had abnormal chest X-ray changes, we'll repeat the chest X-ray and see if there are changes. If those chest X-ray changes were still present, we proceed to CT in scan in order to look at their lung window, see if there's any fibrosis there. We've produced a TQuest breathlessness panel, which looks at causes for breathlessness, and what we're looking there is for D-dimer. If D-dimer is still up, that should precipitate to have a CTPA to look for residual pulmonary embolus. We've spoken to our cardiologists and BNP is on the panel, and what they suggest is that if the BNP is raised, they go on to have an echocardiogram. If they've got chest X-ray changes and still breathless, a spirometry if appropriate PPE in place, or if not, then we are doing pulmonary function tests in the trust for this. Any abnormal results we discuss with us over advice and guidance or our local MBRN MDTs for both North Lancs and Furness. And if stuff is normal but they're still symptomatic, please send them to rehab, because that will address their breathlessness, cough, if they've got a breathing pattern disorder post-COVID, look at their post-viral fatigue and graduated exercise programs. And if they're still symptomatic post-rehab, then at that point we say to reviewing the respiratory team. But I'd just like to say that actually this is a prolonged recovery for these people, and people can be symptomatic for a long time post, because of course this is an inflammatory condition, and even a pneumonia takes at least 2 to 3 months to get better with a bacterial infection, and these people quite often have multifocal or multi-lobar changes which are more extensive than we'd find in a bacterial pneumonia. So second thing to consider is actually the community cohort, or what is now being called long COVID. So long COVID is a relatively new entity which we've been seeing in lots of places, and it actually applies to symptoms which are persisting beyond 3 weeks worth of infection with COVID-19. And the reason why it's called long COVID rather than post-COVID or post-COVID syndrome or recovery from COVID is because the debate is that we cannot tell whether these people have cleared the virus. From the numbers that are being postulated in various places, it appears to affect 1 in 10 of those who've had COVID. And I think what is concerning about this is that it is a young population. They were extremely fit and healthy prior to this, running around, looking after children, doing exercise. And it appears to be particularly anecdotally, from what I've been hearing, affecting those who like to exercise. And I think that this could have, as again, another economic impact. So this is the latest. I know it's a very busy slide, but it can be obtained it's a free access slide produced by the BMJ, and it just looks at all of what we should be looking at from the long COVID within primary care, taking the history, looking for temperatures, heart rate and rhythm, for palpitations, blood pressure, respiratory examination, pulse oximetry to see whether people are desaturating. And people have been monitoring their sats at home and in primary at home with home bought oximeters, which to look at this, and that has been a common referral certainly to me in secondary care, where people have been still desaturating on exercise, but actually when you talk to them, this has been improving over time. They very much advocate what we've been doing, which is full blood count, CRP, D-dimer, BMP and troponin to look for potential causes, and from there advising referral on to the appropriate specialties. So especially if they think they've got a new pulmonary embolism or ongoing pneumonic features or ongoing fibrotic changes, cardiology if you're suspecting a cardiology sequelae, and finally I don't think we can forget that a number of these have potential neurological features including brain fog, memory impairments and potentially having had an encephalitic picture. And finally, the very much of saying to people that we understand that they have ongoing symptoms. And the key message of what I've read from this is that we should be providing support with appropriate investigation and ongoing rehabilitation. So what are we doing locally? First, and this is what has been suggested on one of the Facebook sites, that this is what is prolonged, this is what people are saying when they're seeing. So they're talking about palpitations, tachycardias, weakened immune systems, brain fog, cough, dizziness, anxiety, constipation, itchy skin, and of course loss of appetite and the profound fatigue and muscle aches and pains that they've been seeing. So locally, what are we looking at? Please assess as per our MBRN document. Do a chest x-rays if they've got a fibrotic change, the bloods to look for what we talked about, including cardiac features, clinical assessment to see are they tachycardic, do they have crackles, do they have any clinical findings, spirometry and PFTs if we're looking for respiratory cause and post-viral fibrosis. If you're suspecting cardiac causes, please investigate as per cardiology. And what they're saying is if the BMP is normal, then actually at present, they're debating whether echo is needed, but if they do have palpitations, they need 24-hour tapes and ECGs, and then please refer to the rehab pathway for these patients. And I would say that we are extremely lucky to have this locally, as I think we are one of the few places which does. So going on from here, looking at this, so we've had £10 million announced nationally for long COVID clinics. Be interesting to see what shape and form this comes in. There's a national website or a national web page for looks at your COVID recovery, which advises on cough, breathlessness and other factors. There's been put to get together a research task force to look into this. And finally, there's been a FOSP COVID study, which stands for Post-Hospital COVID Study, which actually aims to recruit 10,000 patients post-discharge and look and see what people's outcomes are from this. And it seems to involve the majority of the great and good of the respiratory world. And this is run by Chris Breitling's team from Leicester. And this may provide pointers in the direction and advice on where to go in. As part of this, there was a series of lectures from the BTS and interaction sessions, which we found very useful, and that's where I've got a couple of our slides today. And finally, thank you to all those who've been involved in COVID pathway, certainly from myself, so Karen Donson, Alison Brenton, Pat Haslam, Wendy Gill and Dee Horton being the managers involved, and all the rehab teams who are out there. Thank you.
Brilliant, thanks very much, Catherine, that's grand. So we've got 14 minutes to have a quick Q&A. So I'm just going to mute this computer here so it doesn't get confused. Right, so I've not got anything to say. I've got a couple of questions I thought I'd ask of Tim and Catherine. So if you could both, Catherine and Tim, if you could just unmute now so you're ready to answer. There's two questions so far in the Q&A session. One is just Mandy asking about can the slides be sent out? Yes, we can send the slides out. It's also, remember, being recorded, this session, and you'll be able to watch at a later date. My first question, let's send this to Tim. I feel like a radio presenter here. Tim from Mostwick asks, well, I'm going to ask him a question, basically. Just a lot of talk has been about exercise desaturations. This is where we put a pulse oximeter in the patient community and get them to walk around the car park or the consultation room. And we see this a lot, don't we, of pulses going up quickly and saturations dropping, although they seem clinically to manage it quite well. My question really is to say, do you think this is useful in the initial assessment of the patient with COVID, and what you would do if you saw it in a patient, how it might alter your management plans?
That's a good question. I think at the moment, if they were resting. I can't hear you, Tim.
Sorry. Oh, sorry, I can't hear you.
You can. I think if we are basing it on their kind of resting sats, whether we start them on steroids or not, for example, or whether we admit them. I'm not doing a walk test. So for example, at the weekend there was a lady with consolidation radiologically. But no real breathlessness, and was fit to go. Sats were 98% on room air at rest. Now, I didn't walk her up and down and see if it dropped, and I suspect she would have got tachycardic if I'd made her do a 6-minute walk test, but I don't think it would have changed the management. It was a sensible lady who could go home. And I think my experience with the first wave was the ones that are going to progress to severe disease, it becomes very clear whilst you're observing them, respiratory rate goes up and their oxygen requirements do increase. So I don't think we're necessarily disadvantaging those patients by missing earlier. It is a good question. I mean, whether or not, if the very early stages, if you saw some exercise desaturation, you might do something differently. Now, steroids work is a good question. So I think, as with everything, we have to base it on our clinical judgment. If the patient is very symptomatic, then don't just allow a normal SATs at rest to put you off asking a question about admission or steroids. I think we should keep an open mind. If that is a question.
So there's a couple of questions are coming in now, so I'm going to whiz through them. There's someone here asking about COVID patients in the community and steroids. I'm going to combine that with another question that has previously been raised outside this meeting, which is whether frail patients who are immobile and have COVID positive, should they be on prophylactic Clexane? Is a question that comes. So the question is about in the community not getting admitted. Is there any value in prophylactic Clexane, and is there any value in steroids? I'll give this one to Tim, and then we'll move to Catherine the next couple ones.
It's a valid point with the Clexane, but I think whether it truly affects the actual mortality of those patients, it would be very experimental. without evidence, and I just don't think there's enough to say yes or no to that. If someone's so frail that they're kind of bed bound and not appropriate to have a hospital admission, I mean, I think we need to be careful. At the beginning, we had this mantra, which I'm sorry to see creeping back in, about protecting the NHS and all this. Personally, I find it an unhelpful comment. The NHS is here to look after patients. In some settings, it might have been interpreted that because we were expecting an absolute tsunami of activity, that anyone who's really not going to be with us perhaps for another year or two anyway shouldn't even grace the door of the hospital, and I think we began to feel that wasn't really appropriate. We had plenty of capacity throughout the first wave, admittedly because a lot of other conditions stayed away, but I personally don't think that capacity is going to be as much of a problem as the media would like to tell us it will be, and therefore if patients should be coming into hospital, they should come, because they may just need a few days of oxygen and some good general nursing care and pull through. So for those where it's definitely inappropriate, I don't think the actual mortality reduction would be very great with the heparin. So I think it would be complex and potentially lead to side effects that would be difficult. But I appreciate it's a bit of a tricky one, that one. Don't know, Catherine may have a different view, but in terms of steroids, the evidence I think is clear that if they don't need oxygen, they're not going to benefit. If it is a community patient who is insisting they don't want to come into hospital, but is needing some home oxygen, perhaps it was our COPD patient whose oxygen requirements have gone up, but they're clear they don't want to come and they've got the right support to be able to give oxygen, I don't see any problem with giving steroids for that patient, and you know, we could give advice over the phone if need be, or advice and guidance if there was a question there. I think it's common sense, isn't it? The data tells us that those severe patients who need oxygen will benefit from steroids. That doesn't matter whether it's in hospital or not, and it's an easy job to give, providing the patient didn't have major contraindication to a steroid. So I think it's got to, in the end of the day, be an individual patient decision.
Bro, so Catherine, there's something here, Kate Brown. So initially they were suggesting to aim for saturations of 92 to 96% in these patients. Is this still the case? And can you explain why they recommend this? So is there a particular target saturation when managing your COPD, your COVID patients?
So I think if you look at oxygen generally has changed over time. Before we used to aim for higher oxygen saturations, and actually increasingly we're seeing that oxygen is toxic. So we used to give high flow oxygen to a lot of our patients, including our post-MI patients, in order to provide extra oxygen to the myocardium, and actually that was shown to cause harm. And increasingly we see that by aiming for anything above about 94 to 96, this causes harm, and this has gone down to as low as 92 recently. And I think that's what it is based on. It is based on our knowledge about oxygen in general rather than anything within COVID.
Bro,
I agree with
there's
that.
another question here that says prednisolone question mark, so that'll be the same answer as Tim gave to Dex, as dexamethasone. I think that's what that question's getting at. There's a question here about, it says long COVID, do we need to code in primary care? And please can you confirm the definition again? What I suggest on this is that we're going to do this a bit more depth, primary care, in the second session on the 4th of November. So I'm going to go a bit more detail into what we would recommend in primary care. There's not a long COVID code, there is a post-viral illness code, but I think at the moment there's no need to worry about what you code and what you put in there, as long as we're capturing the symptoms and the data. But I can go through this a lot more on the 4th of November thing. I just wanted to also, got a few minutes later, I wonder if Catherine, could you, one of the things we see with COVID, isn't it, you can initially present with symptoms, but the delay from presentation to admission or deterioration could be longer, can't it? So it's just maybe something on what you've seen about making sure we're following up once we've initially assessed the patient, because they can deteriorate after you've seen them at day 2 or 3, for example.
So I think there's actually quite a lot of debate about this. I think it's safety netting, because we see the post-initial, don't we? Then we see the inflammatory surge approximately week to 10 days later, and which would be interesting to see what Tim's thoughts are on this. So it's making your safety net, making sure we safety net about the shortness of breath, making sure we safety net about symptoms. And there has been a bit of a discussion nationally that they have obtained a number of pulse oximeters nationally to monitor these patients, and I think there's a big debate on how those will be used and whether those will be used in the initial diagnosis or whether those will be used on the follow-up, and I think that's something which will continue to happen across the region and certainly provoked a bit of debate already. Personally, I think we've just got to be really careful, and that's where safety netting, talking and revisiting the patient is probably the most important. What do you think, Tim?
Yeah, I agree. The only difficulty I think is with some, I'm thinking about the patient the weekend that ended up intubated. He was still thumbs up and say, I'm going to beat this. I feel much better, just as we were about to intubate him. So I think there's this odd difference sometimes between the actual state of the respiratory system and in particular in younger patients, their interpretation of those symptoms, but there's nothing we can do about that. But absolutely, I mean, most people at day 2 who've got myalgia are going to be absolutely fine, and we can't monitor all of those. But yes, certainly the perhaps in the higher risk groups, I guess, so we know that the older patients, the comorbid patients, certain ethnicities are going to be of higher risk of more severe disease, and absolutely there is talk about using, I think in Manchester, Benita Kane was talking about this in the Northwest Thoracic meeting about getting early discharge or turning around from GP or ED, but with oximetry backup and so on. It's just the infrastructure you need, isn't it? But that'll be interesting. I think that might go forward. But safety netting, maybe getting a relative or partner or someone involved who's, if you can, to as a second opinion, just to really reinforce this day 7 to 10 message.
Brill, right. I'm just going to mute this so we don't get feedback. Thank you so much, Tim and Catherine. That's been brilliant. Thank you for everyone who's put in questions, and thank you very much to Suzanne who arranged it all. So the next, the second one in this program will be on the 4th of November at 12:30. We'll make sure that more emails go out prior to that with the link. We'll make sure we share the slides from today, and we'll also send a link round to the video, the recording of the session. Brilliant. Right, thanks very much, everyone. That's a wrap.
Thank you very much.